Health for our session on the transition from nurse to RN, LPN, CPC. We will also be covering how to audit as a nurse. I'm your host, Maggie Stankiewicz, and I'm pleased to welcome you to today's event. Before we get started, I'd like to give you a little bit of background on Advize Health. At Advize Health, we analyze processes, implement solutions, and deliver quality educational opportunities for healthcare entities of all sizes. Advize Health has been in existence for over 13 years and employs the industry's top auditing and consulting experts. We offer an extensive catalog of services, including HIPAA and compliance analysis, medical documentation auditing services, and educational opportunities for a number of specialty-specific topics. The educational seminar that you are about to view is just one of many services that Advize Health's advisory sector has to offer. We provide the medical billing and coding community with 30 free CEUs per year through our monthly webinars and coding newsletter. Our priority and promise to the healthcare community is to always tailor our services to our clients' needs and budgets. Today we have an exceptional speaker, our very own Judy Ward. Judy Ward is a nurse auditor at Advize Health. She has over 20 years of experience in auditing and coding in various industries. Prior to coding and auditing, she was a perioperative nurse working in various hospital settings. Now, for some general housekeeping items. If you have any questions throughout the presentation, please send them to all organizers. We will address your questions during the Q&A session at the end. The webinar will be recorded and sent out to all attendees, along with a PDF of the presentation, within 3 to 5 business days. Keep in mind that this presentation is not worth CEUs, although next week's webinar on navigating MACRA will be worth 1.5. I'll now turn it over to Judy to begin the presentation.
Good afternoon, everyone, and thanks for attending. I'm happy to be speaking to a bunch of nurses who are interested in becoming CPCs. What we're going to go over today is up on the screen here what our agenda is. We're going to talk about what a CPC is. Maybe some of you know, maybe some of you don't know. That's why you're on the call. We'll discuss what actual code is, being certified in coding, why you should become a coder, certified professional coder, where you are now in your nursing career, and where you could be in the future, and how to get there, how to become a coder. So here's the definition of what a certified professional coder is. It's a healthcare professional who's demonstrated knowledge of medical coding, which includes the correct application of current procedural terminology. Those are the CPT codes, International Classification of Disease, that's the diagnosis codes, and then you have your HCPCS codes. So if we go into, and also I forgot to mention here, the AAPC is who governs professional coding. You obtain your CPC by taking an examination that's provided by the AAPC. And it's really considered the gold standard in coding. It's the most recognized coding certificate in the healthcare industry. There's 4 basic coding certifications to get, and then there's also multiple specialty certifications you can get in many different areas such as evaluation and management, anesthesia, emergency room, cardiac, OBGYN, and many of them, which would be ideal if you're working in one of those specialty areas. So what we'll do is we'll look at basically what those codes are that I mentioned on the previous page as far as what a CPC is involved in. So the CPT code, that's a term which identifies any kind of medical service or procedure that is performed by physicians. So it could be an MRI, it could be a surgery code, it could be an X-ray, anything like that. Anything that a surgeon does and expects to get payment for, he's going to submit to the insurance company with one of the CPT codes. Then, in addition to that, you have your ICD-10 codes, and those are the diagnosis codes. They are something that pretty much lists exactly why you are there. So if you go into a doctor's office and he does an MRI of your knee, you should expect to see on the claim diagnosis code somehow related to a knee injury. That's why that's really important. Another reason why diagnosis codes are used and they're very important is sometimes they're used to look for clusters of diseases. Like I'm sure everyone's familiar with the Zika virus. That may have, they may have realized that it was an epidemic based on all the different claims that were coming in a certain area. So those claims are looked at the CDC, and they can come in with, and that's how they classify epidemics that way. Same thing with cancer codes. Why they're so important to code the correct cancer code on a claim. If you have a cluster of bone cancers in children, that would be identified, and somebody would look at that and say, what the heck is going on in that area? So diagnosis coding is very important to a coder as well as the procedure codes. And then we also have the HCPCS codes. These are codes that identify medical equipment, medication, ambulance services, prosthetic devices, braces, that kind of thing. So what we'll do here is we'll kind of blend three codes together to give you an idea of what's involved with being a certified professional coder. Anytime you go anywhere and provide you get any kind of service provided. It could be a doctor's office, ambulatory surgery center, home care, hospice, anything where that provider expects to get paid, you're going to use these codes. It could be physical therapy, speech therapy, anything like that. So if you look at the example that I have up on here, now, as a coder, I know exactly what happened here. This happens to be my experience a couple years ago when I had knee surgery. So just to have nurses have their own kind of lingo, where you may say, like, we all know that HS means at bedtime, or, OS is left eye. It's the same kind of thing when it comes down to coding. Anything that's on that document where that physician wants to get paid, he puts onto a claim with codes. So, for example, we'll go through this. The 99243, that's an E&M code. A lot of people don't even know what that stands for. It's an evaluation and management. It's basically your doctor's office visit when you go in. That's all that means. And there's different levels to it. If you're a new patient, if you're going in for a consultant, if you're an established patient. So for this case, I went to the orthopedic doctor because I hurt my knee skiing. Okay, so when he submitted the first claim, what he did was he did an E&M, which is a 99243. Then he had a 73560, that's a knee x-ray, which he did in his office. Then we have the J code, which is the medication that he injected into my knee. And I actually forgot to put in here, there would be a joint procedure code as well. I think it's for, I forget what it is. I believe it's in the 6,000 range, but it doesn't matter for this example. And then I have the diagnosis code here. The diagnosis code is important because when you look at this is saying in code language that this is a meniscal tear of the right knee, and I'm there in my initial visit to the doctor's office. Then when I go back to the office the second time around, I get another E&M code. Now this code shows me the 99213 that I'm already an established patient. So it's different than the first code, and that differs by the last 3 digits in that code. And then the diagnosis code there is kind of the same diagnosis as the first one, except the D shows that I'm a recurring patient for the same injury. And then what he did was he ordered a knee MRI. That's the 73721. I had that done. And it just showed that my knee was pretty badly torn. So I went in and had a surgical arthroscopy done, and that's what this last code is, the 29870. And then the L code is a HCPCS code, and that was a knee immobilizer. You can see here where all 3 of those codes get blended together in order to show a claim that this one orthopedic surgeon sent in to treat my knee, and why it's so important to code correctly. So I'm sure this is the big reason why you're all here. Why do nurses want to become CPCs? I mean, I listed a lot of things here. Maybe you're ready to leave the clinical work environment. I mean, maybe it's just too grueling. Maybe you're sick and tired of working, every other weekend or 12-hour shifts and holidays. Sometimes you just can't keep up with the rigors of nursing. I mean, I was an operating room nurse for years. I can't imagine running around an OR now. I just can't imagine doing it, and I work 12-hour shifts. A lot of nurses are being forced into getting a BSN. Now, I'm from the New Jersey area, and a lot of my friends in New Jersey are being forced to get BSNs. Even though they're already employed at the hospital wants to get a magnet status, and they're making them all get BSNs. So, here are these women who have been working in nursing for 20, 30, 40 years. All of a sudden, they have to go back to get a BSN. I'm not dogging a BSN, I have one, but I don't think, if you're already a nurse without a BSN is not going to really get you any more clinical experience that you already have if you've been working, for 20, 30, 40 years. So that could be one of the reasons. Sometimes a lot of coding positions are available to work from home. So that's a definite option if you're sick of traveling, commuting. You got to worry about snow and that kind of thing in the wintertime. It would be an optimal thing for you to do. Sometimes people just had it with, they just want to change. I personally, I went into this line of business not because I wanted to change. I love the operating room. I did it because of childcare needs. I just couldn't be there to put my son on the bus anymore, and my daughters were in a different school. So I made that change. And how I started out, which could be actually perfect for some of you, I started out part-time doing this. I answered an ad. They were looking for an auditor, a nurse auditor, to review hospital bills. I had no coding experience, nothing like that. But what I did, I worked in the operating room. So when you think about it, the operating room has the highest amount of charges, I think, in any area in the hospital. Now, I could be wrong. I haven't been there for a few years, but it was pretty significant. When I was there, I think they were charging $800 an hour just to be in the operating room. That includes the nurses, that includes, the linens, that kind of thing. But anything that was used besides the instruments was an additional charge. So I ended up, I got this position based on working in the operating room. I was able to, explain to them that if you hire me for this, I can really save your clients a lot of money. I work in the OR. I know what's going on. I know if there's a charge on there that says 3 Bovie pads. Who knows what Bovie pads are? OR nurses know what Bovie pads are. Okay, it's a pad they put on its electrical grounding unit for the cautery machine that they use. A lot of people don't know that. Don't know that. So they may look at that bill and say 3 Bovie pads. Oh, I guess they're just pads for positioning or something, and they pay the bill. So that's really how I got started. And then I did that. Oops, sorry, didn't need to do that. I did that part-time, and then I eventually, like I said, with the child care issues, I ended up working in the industry for full-time and left the OR. Another good reason to get into it is maybe you've been out of the workforce for a while, out of the clinical area, and now you want to get back in. Maybe you stayed home and raised your children. You think, you know what, I want to get back to my career, I want to go back to nursing. Good luck getting a job in clinical after being out. It's almost impossible. So this would be ideal. You have all your nursing experience, all your knowledge in your head. You take the coding course, get certified, and you can find yourself a different, a different position without having to. I know in some states, if you're out of the clinical for a while, they make you take a course, or they make you take your boards again. I don't think that's an option. None of us would want to have to do that. Another big reason is, well, for me personally, and we're going to have the slides after this portion about auditing as a nurse. That's what I do. I love auditing as a nurse. You get to use your knowledge. I get to research things, look into things, investigate why was this done, why is that done. I really enjoy it, so I'm a big proponent of that piece of it. And also, it could be part of controlling costs. There's been times that I speak all the time to my family and friends that I know about, different codes and how they're being billed. I'm a big advocate for helping people with their claims. They get their statements, their EOBs from their doctors. A lot of people don't even look at them. A lot of people do. My daughter is one of them who looks at them. Her friends look at them. So, I'm always preaching about healthcare costs and that kind of thing. So I'll tell a little story. One of my daughter's friends took her son to the pediatrician for his well visit. Now, you won't know. This has to do with coding. I mean, you know, but you'll get the gist of this, why it's so important with coding to make sure that things are coded correctly and why we audit claims. She took her son in for a preventive visit. Now, preventive visits or annual visits that any age group goes to the doctor for. He just happens to be a child. Everything's included in that. You know, there should, and with the Affordable Care Act now, there should not even be a copay with that. Well, it just turns out her son had got an ear infection like the day before. So she just figured, well, you know what, I'm going for the preventive visit. I'll take my son in, and I'll just ask him to check out his ears and see what he, you know, what he thinks about it. So in the preventive visit, it includes looking in a child's ear. But what this doctor did, yes, he looked in the ear, he wrote a prescription out for amoxicillin. What he did was he built another evaluation and management service on top of the preventive visit. Now, there were times when that can be done, and that's all in coding guidelines. But in this case, it was not valid because you need to have a substantial amount of documentation that you really did a lot of extra work in order to do this. So she's going to get the actual records from her doctor's office, and I'm going to look at that for her, and we're going to help her write a little letter in order to get her copayment back. All right, so I'm done with my preaching about that. So why nurses should become CPCs. Nurses know their way around a medical record, I think, more than any other healthcare professional. I mean, how many times, I know when I was working in even working on the floor, you know, well, this is dumb, I'm dating myself, but you go back to reading the doctor's orders on the chart. I mean, some doctor's writing was horrible, but, you know, some of us could make it out and we knew what it was. I think when you're reviewing medical records, some of the writing is horrible if you happen to be, you know, reviewing records that are actually handwritten. A lot of records today are electronic and they're typed. But what's great about how your nursing knowledge really helps here is that you can look at the record, and if you look at the context of what it is, you can really figure out what that doctor is saying in there, where maybe a coder who doesn't have the nursing background may not be able to put together what that little thing that the doctor wrote is, how it's not making any sense. But when you look at the context of what the note is, you can figure out exactly what that means and what he's trying to say. You already know anatomy and physiology and disease processes, so that would certainly help you when you try to look at a medical record and extract any kind of information. And applying the correct code that corresponds to applying the correct codes correspond to appropriate billing. So in doing that, by applying your knowledge and applying the correct code for the service that is documented, I mean, you're certainly helping the financial well-being of everyone involved. I mean, maybe if you're auditing a provider who's doing abusive practices, you're not, but in the long run, you're helping the overall population and insurance companies' payments as far as not paying for anything that's not necessary. Where you are now, a lot of nurses work in, well, these are just a few of the areas where all of our nurses work. But like I said, I started out in the operating room. I worked in ambulatory surgery centers. I did audits in all these areas, and you know, certainly working in one of these areas can certainly benefit you when it comes to doing an audit in that area. And also the AAPC actually has specialty credentials, as I mentioned earlier, for the different areas. I would suggest that anyone should get the basic credential first, the CPC. It makes you more marketable. And then if you do have a specialty area that you know very well, go ahead and get that specialty then, and then you have an added bonus, which can make you more marketable. So where you can be. A lot of these are jobs that maybe nurses have never even thought where they could work. I worked for a while. I worked for a national healthcare company, insurance company. I was an audit manager there. I had nurses that were CPCs working for me. I also had CPCs working for me. And what I did was I audited the department where we looked at all, well, we couldn't look at all of them, but we looked at our provider base. We looked for fraud, waste, and abuse and claims. We applied our nursing knowledge most of the time to to review the medical records. So that's an option. Also with insurance companies, they have policy departments where CPT codes and ICD-9 codes are associated with the policy. So you could work with the policy department in writing policies and researching what procedures and diagnosis codes would apply. We're going to discuss this later in the medical necessity part of auditing. These claim policies are huge when you're doing an audit and you're basing it on medical necessity, because nurses can't deny anything for medical necessity. But if you have a good written claim payment policy that says, for example, only 1 or 2 ultrasounds are medically necessary for a normal pregnancy, and you're looking at an audit where they're billing an ultrasound every single month, well, then you have your policy to base your medical necessity on, where you're going to deny it and say, oh, those ultrasounds aren't medically necessary. You can work in medical management field. There's a lot of companies that just manage, for instance, automobile claims and anything associated with bodily injury. Those companies hire nurses and CPCs. They have products where they look at just specific codes to see if the providers are billing them correctly. Software applications. There's a lot of applications like McKesson and Interqual. They use CPT codes and diagnosis codes to apply a lot of their guidelines. You can work in a physician's office, you can work in attorney's offices, even CPA offices, accountants. A lot of those groups actually do auditing, and the same thing with attorneys. Attorneys, like I said, I worked for a large national insurance carrier. Most of the time when we had large findings, the physicians would hire an attorney to defend them. So what the attorney would do, the attorney would hire an auditing group, could be you, or even just they had their own individual one in the office, and they would, review our audit results and, try to defend their position. Oh, I did that again. Defend their position on our audit. There's the education piece. You could teach not only providers. A lot of providers think they could do their own coding. They really can't. They don't learn anything about this in school. A lot of good offices will hire a coder in order to submit their claims. Some don't. What happens there is the providers need some education. They'll get their audit done, and they're like, why? I didn't realize that I couldn't do this. So there's a big market for nurse CPCs to educate providers. Because unfortunately, well, fortunately and unfortunately, we nurses are used to speaking to doctors, especially when I worked in the operating room, work very closely with them. We can have a rapport with them. It's different when nurses speak to a doctor and a coder, and there's no disrespect to coders. Sometimes the doctors just have that mentality, not all of them, they have that mentality that they want to speak to someone in the medical field. They'd rather speak to a nurse telling them what they're doing incorrectly than a coder. And then also a consultant or an auditor. That's what I do. I work for Advize, and I'm a nurse auditor there. So how you're going to get there? Our company Advize actually has a couple courses that are available that can help you become a CPC. What's great about it is it's geared to nurses where you're not going to have to take the anatomy and the physiology courses. You already know that, so it would be a much easier transition, a much easier way to take the test if you use a lot of your pre-existing knowledge that you know. If you'd like to know anything about that, you can certainly email. The email's up there. And also you can actually go onto our website and see there's a lot of different programs available if you'd be interested in that. We're going to move on to how to audit as a nurse. So what I'm going to kind of go through is what my day is like. Maybe that would kind of help give you a better idea of what a nurse CPC does. Like I said, there's many different areas you can go into. Like I said, the insurance companies, you can work for medical management software, lawyers, attorneys, that kind of thing. But what I find that I like to do best is to do auditing. So that's what I'm going to speak about as far as what you as a nurse can do. We'll go over the audit scope, coding versus auditing. There is a difference. Applying guidelines to your audit, actual auditing, and the medical necessity portion of the audit, which is it's very important. So the audit scope is it's really what your audit is. You need to focus in on the scope of your audit. It could be based on a particular provider group, a particular CPT code, or some type of allegation of fraud, waste, or abuse. And medical necessity really should be included in all of these audits. I can give you some examples here. If you're going to look at a provider group, you can look at a group of ER physicians. Some of these ER physicians are in a group practice. They may practice at 3 or 4 different emergency rooms. And when you're looking at what claims they submit, some of them submit a very high-level evaluation and management services compared to their peers. And when I spoke earlier about evaluation and management codes, those are the codes, again, where you go into your office you go into your doctor's office for a visit. Same thing in the emergency room. If you go to the emergency room, they're going to bill an evaluation and management code. It's a different set of codes, but it's the same thing. And there are requirements that need to be documented for each code to meet the particular level. There's levels, I believe in the ER, there's levels from 2 to 5. Doctor's office, they're 1 through 5. So you may have an ER group that's billing all level 4 and all level 5 office visits. It's highly unusual. So that would be, the scope of your audit would be on that particular group then. To look at, you would also, look at their peers and try to figure out why they're billing at a higher rate. Probably they don't have the documentation to support it. Then you can also do a particular CPT code. I mean, you might audit, like I said, knee MRIs. You may look at those to see, could be a medical necessity audit. You may be working for an insurance company, and you do have a claim payment policy that indicates why a knee MRI should be performed. So you could look at that and see if the documentation in your physician's record that you're looking at meets the criteria in order to order an MRI, and then also to perform the MRI. And if the documentation on the report meets all the criteria for that particular code. And then additionally, every claim would have the an ICD-9 code, or 10 now, and that would be the diagnosis listed for the claim. So you may have all these weird diagnosis codes being built. So that might be something that you want to look at to audit. So there's various different scopes of audit that you can have. So I think I kind of went into this a little bit of the previous slide. So you can have, the CPT code. If you want to audit that, it could be that maybe the CPT code changed from year to year. I don't think I mentioned this before. The CPT codes are put out by the American Medical Association. So they look at the codes every year, and sometimes they revise them. Sometimes they delete codes. Sometimes they add codes. Sometimes they change the description of the code. So there are times where if they change a description of a code from year to year, the next year, maybe 6 months in, would be the time to audit that code, because what you may find is the providers are still using that code in last year's description, where you may find some lacking documentation, or maybe there's something that they didn't do and they're getting paid for this code when they really should be billing another code. Let's see, policy. You may, I think I already mentioned that, you may want to audit just a particular policy, like I said, with the knee MRI, the particular provider group. Yeah, I think I jumped ahead of myself a little bit here. Contracting. You may want to audit provider contracts. Scope of the audit, that could be used there. You need to look at that as well. Sometimes in the insurance industry, the insurance carriers cater to a certain particular provider group where maybe there are not a lot in their network, so they're going to give these providers special things in their contract, which allows them pretty much to bill maybe all high-level E&M codes where they don't have the documentation. So that's something that you would need to look at in your scope. And also medical necessity. Medical necessity is huge, and I really think that's what keeps nurses, it differentiates nurses from coders. I'm not saying that coders can't audit medical necessity, not at all. But I think nurses have more insight into why something may be medically necessary that maybe isn't written out in the documentation that can be inferred. Maybe you look at the lab value and you say, maybe it's not written that, well, he needs, I can't even think of anything right now, but you know, he needs, okay, he needs a glucose monitor, okay? That's a lame example, but there are times when you can infer that something is needed just by a lab value or something that's written, a symptom or that may not be picked up if you're just kind of looking for specific documentation. So that's where I think nurses stand out as medical necessity. And then you may look at the diagnosis code that a provider put on a claim. He's saying that you know, the reason why this patient's coming in every week, they're billing like a diabetes diagnosis code. When actually, when you look at it, I mean, there's absolutely nothing in the record for a diagnosis code of diabetes. They just may have this person coming in every week because they can. It's abusive, and they just want to get paid for claims. Here's where I have down what coding versus auditing is. Coding transforms the medical record into procedure, diagnosis, and HCPCS code to describe the services provided in order to bill and obtain for reimbursement. So this is something that you may have a doctor's office may hire a coder in order to do the coding based upon his visits of the day. They would look at whatever he did that day, the documentation, pull out the codes according to the guidelines, and then they would be able to submit those claims with the codes and the diagnosis codes that is fitting for them. Auditing is different because auditing actually reviews the coding based on accuracy, based upon the guidelines, claim payment, and clinical policies. So you're not assigning codes, you're actually looking at the codes to see if they do fit, if there is a reason to do it. I mean, you can have beautiful documentation for, you know, some type of, say, an EMG or X-rays, but if there's no medical necessity, if there's nothing in there as to why they're doing it, that's a problem. That's where you would come in and do the auditing, and that would really be based upon medical necessity. Coding, yes, coding, they meet everything. It's beautiful documentation. They have everything you want to see, but it shouldn't be done based upon the diagnosis. Another thing with doing auditing, what you need to do is you need to look at your specific carrier guidelines. For the carrier I worked for with the national plan, they had 4 different lines of business. They had, you know, there was a commercial plan, health plans, there's Medicare and Medicaid. So it's another thing you need to look at when you're looking to audit. What line of business are you looking at? And what specific guidelines apply to your audit. Here we go. They have all different lines of business. There's federal plans, there's self-insured plans, commercial groups, Medicare, Medicaid. You also have workers' compensation claims, and then they have all of their own rules and regulations. You have liability insurance, such as the personal injury protection, which is your automobile industry. They have their own rules and regulations. They don't have many. They need more. But that's what you would need to, when you're doing your audit, you need to have all that information in front of you so you know exactly what you're going to base your audit on, what guidelines you're going to use. Because if you deny something, for whatever reason, you need to have some kind of backup, some guideline regulation to support why you are denying that, or else they said how the physicians hire their attorneys, you're going to have to answer to them exactly why you put that in there. If you have nothing to base it on, it's just not going to work. So our auditing process here. So we looked at the steps. We talked about the scope, lines of business, guidelines and regulations. The next step in the audit is actually coming up how, when you do your audit, where are you going to put all your information? So you're looking at all these records, and I'll say also, you most likely you have a spreadsheet with all of your claim data on there. And what you need now is you need to have some kind of audit tool, what we like to call it, where you would enter all the information that you're getting out of your documentation as you're auditing. So we have our audit tool. What's an audit tool? Okay, so it's usually in an Excel spreadsheet. In addition to the claims information, which it's going to have your provider's name, his ID number. You're going to have all your patient information on there, date of birth, date of service of the claim, the CPT code that they're billing. We didn't talk about this, but there's such a thing as modifiers. Modifiers, that's exactly what they do. They modify the CPT code that's billed. There's guidelines around them. You're going to have your ICD-10 code, which is your diagnosis code. There's also CPT codes where you can bill 1 to multiple units, depending on the description of the CPT code, so that would be an area. You have your area of comments where you're going to write anything that you think is pertinent to your audit. A lot of providers, when I talk about providers, I'm talking about insurance companies. They're going to have, I know if I talk about them as doctors as well. In this case, I'm talking about them as an insurance carrier. A lot of them have signature requirements. Some of them will take a signature without a date. Some need to be dated. There's certain requirements for electronic signatures if you have electronic records. So that's something you need to look at. So that would be something you could put on your tool, whether or not your signature meets the requirements. You can add in there any kind of guidelines or regulations that you're going to follow in your audit. And you can have in there also denial reasons. It could be like a drop-down box. Either it wasn't medically necessary, there wasn't a record, there wasn't enough documentation to support the code, it's a non-covered service, they didn't follow the policy. And then also what you could put on here is red flag items. That's something that maybe your insurance carrier wants to know if there's anything weird you see with the claim. I mean, maybe when you're looking at this one doctor's records, you notice that he's ordering, say, a complete blood count on every patient that walks in the door. So the diagnosis codes don't support it. You look at the medical records, there's absolutely, there's no medical necessity to be having a CPC done. But meanwhile, he has all the documentation there, so it meets the coding requirements, so you can't deny it on that. So what you would do here is maybe put in a little note to your insurance carrier that you notice that this doctor is billing a CPC for every patient that comes in. I mean, that would be something that would be a red flag. Same thing with the diagnosis codes. Maybe your diagnosis code didn't fit. You have a broken finger, and the diagnosis code on the claim is a, diabetes again. I mean, that wouldn't fit. Another thing you can have on your spreadsheet, I don't know how many of you are familiar with Excel, but there's multiple different sheets that you can have in an Excel spreadsheet. And one of your sheets could be all of your guidelines that you're going to use. So you can just have those all listed on one of your pages that's easier to refer to. You can number them, and maybe then you can just apply that on your audit tool as far as why you're denying that case. Could also put in there all your different CPT code guidelines. It just makes it easier when you're auditing to have all this information at your fingertips. I don't like to write many things down on a piece of paper. I like to have everything on my spreadsheet. I mean, it makes it easier even at the end when you're submitting your results to your insurance carrier. They can filter on it. They can see maybe out of 100 claims, we're not allowing this because with the evaluation and management claims, this particular doctor is, he's billing for a high-level exam, but when we look at it, the exam, I mean a high-level procedure code, he's not meeting the criteria where his exam is not a comprehensive exam. I'm probably talking things that you're not familiar with, but this may be somewhere where if the insurance carrier filters on this, they may look at this and say, you know what, we're not going to take the money back from him. I mean, he did provide a service, not that high level of service, but what we're going to do, looking at this, most of the denials are based on not meeting the requirements for the exam. I think what we're going to do is just educate him on how he should be billing the lower level. That's how they use that information. And then what they may do is they may ask you to audit them again another 6 months and see if they're actually applying the education that they went over with them. Medical necessity, like I said, that's huge. It should be a part of every audit. So there's sometimes you may be auditing a particular policy where claim payment policy where they say, like for example, if you're doing home oxygen audit, there may be guidelines in there where the pulse oximetry needs to be measured. It has to be less than 88%. So you look in your record for that. You would have a column in your spreadsheet, you know, O2 saturation lower than 80, yes or no. It's just an easy way to get through your audit and have all the information in front of you instead of writing it down on a piece of paper or even putting it in your comment section. I mean, the least amount of text that you can enter is going to make you much more productive and efficient. Then we come to, okay, so I talk about medical necessity. What is medical necessity? Well, there's a lot of different definitions for medical necessity. The government here has their own definition. That's according to the Social Security Act. The AMA has a different definition of what medical necessity is. What I like about using the AMA definition, if you can use that, is they actually, right on there, they have in their accordance, under A there, it's in accordance with generally accepted standards of medical practice. So what you can actually do here, if you don't have any kind of claim payment policies to base your decision on with your audit, you can go in here and you may look up, say you're doing an OB audit, and we'll bring up the ultrasounds again. You know, say you have a normal pregnancy and you have this OB provider who's billing the company for an ultrasound every single month as the patient comes in, and you know, the last month, every single week the patient comes in. Well, the documentation is beautiful. It's all there. He sends images. He writes up a nice report. But when you actually look, you know, you realize it's not medically necessary to do that. There's no diagnosis code. There's nothing in the record. You can actually use the standards of care that, and most of these specialty groups, they have all of their position papers on their websites, which is really nice, and you can base your medical necessity denial on that. So going back to auditing as a nurse, the most common starting point to support medical necessity of any procedure or service billed is the diagnosis. You need to look at the diagnosis, because if the diagnosis does not support why they're doing what they're doing, you're going to have, it's going to be a denial. Everything needs to mesh. And evaluation and management codes. There's 3 different sections in E&M codes. You need to have, there's a history, there's an exam portion, and then there's the medical decision making. That's where your medical necessity piece comes in. If somebody comes in, you know, for an earache, it's going to be a pretty low-level visit because the medical decision-making there is pretty low. I mean, you would do just, you know, a minimal exam. You look in the ear, yes, okay, I agree, they have a fever, that kind of thing. They have an earache. Medical decision-making, they have an earache, they have otitis media, that's the diagnosis code. We're going to order antibiotics, they go on their way, very low level. Now, if you see medical decision-making where it's that low level, okay, but then you see in the history and exam where they're doing an exam on every single body part, they're doing a big cardiac exam, they're doing an abdominal exam, they're checking all their extremities. What happens here, they do that sometimes to upcode and get a higher level build. The medical decision-making is what determines the code on these E&M services. So if you're only coming in for an earache, an ear infection, and you have a big comprehensive history, comprehensive exam, it's not medically necessary. So that's where that comes in. Another place where you can define your medical necessity is your local coverage policies. Those are what I mentioned. A lot of the insurance companies have. National coverage policies. A lot of your Medicare and Medicaid plans have national policies, but a lot of them have local plans as well. And why medical necessity is so important. There was a study done, CMS did this, there who run Medicare, that 62% of overpayments are related to errors in medically unnecessary service. So, I mean, it's huge. There's a lot of areas where the documentation, there's certain areas where they pointed out where the medical necessity is lacking. You know, the diagnosis code doesn't match the diagnosis that's in the record. There's laboratory and radiology and tests that aren't supported or they don't have the proper results. A lot of times they're sending in duplicate claims, duplicate charges, medications they write down were given that were not given, and there's a lot of abuse of physical, occupational, and speech therapy. I mean, with physical therapy, you need to see progression in order to continue with it. There are some doctors that will continuously write prescriptions for physical therapy that's not medically necessary. They keep going and going and going, and they're getting passive therapy. They don't progress to anything active. They keep doing the same thing week after week after week. That's not medically necessary. So that's the big problem where this the high error rate is involved. A lot of times, so the diagnosis code, there needs to be a reason why things are being performed. That's what medical necessity comes down to. There has to be a reason why your doctor is billing what he's billing. You just can't bill it just because. If you take your car in for an oil change, okay, you know your car needs an oil change. You know, that's necessary. You go to pick it up, and you see that they also billed you for a new battery. You're like, well, I didn't need a new battery. I just needed an oil change. So it's kind of the same thing. You go into the doctor's office for, you know, a checkup for, you know, your knee, and all of a sudden we're doing a hearing test on you. Why are you doing a hearing test? I don't need that. My hearing is perfect. It's just something to tack on to the claim, and it's not medically necessary. So, like I've been speaking about the whole time, medical necessity really is a defining point that makes medical services justified as reasonable, necessary, and appropriate. It really defines why the provider performs every service that he does. This is why a nurse auditor needs to make medical necessity a part of every audit, because it truly is. There's a lot of fraud, waste, and abuse that's going on. The money that's spent every year in this is atrocious. You know, 68% of claims they found were in error because of medical necessity. It's a big part of auditing. So to sum things up, what we talked about, the benefits of becoming a nurse CPC, a nurse CPC are endless. There's so many different areas that you could go in and work. There's so many areas where you can use your nursing background and experience to just expand upon that and get yourself a new career. Or maybe you just want to work at it part-time, stay in the clinical area, you know, do something, hopefully get a position where you can work at home. You can work evenings, weekends, whenever you want. It's perfect. There's so many different opportunities available in education, in insurance companies, medical management firms, physicians' offices, attorneys, and for consulting firms. And I said, we can help get you there if you want to take one of our courses. I believe we're the only company out there who's actually gearing courses specifically for nurses. And it's important because if you go take a normal CPC course, a regular CPC course, they're going to start with, you know, the anatomy and physiology, and it's just something that your nurses don't have time for anything like that. If we don't need it, we don't want to have to do it. Our course, you know, just gets you what you need in order to pass that exam. I said auditing is much more different from coding. That's why I think it's really good to be a nurse and do auditing, because you can really factor in that medical necessity piece, which is so important to cut down costs and to make everything that your provider is billing, the doctor is billing, make it medical necessity and make it prove that he should get paid for that service. That's all I have. Thank you for listening.
Thank you, Judy.
You're welcome. Are there any questions?
At this time, I don't see any questions, so I'm going to give everybody a minute to submit any inquiries that they may have. In the meantime, I would like to let everybody know that next week on October 27th at 2 p.m. Eastern Time, just like this one, we will be holding another webinar presented by Dr. Phil Smith on navigating MACRA, and that presentation will be worth 1.5 AAPC approved CEUs. Let me take a look here. I don't see any questions, so if after the fact you happen to think of anything, feel free to email education@advizehealth.com. Before we sign off, Judy, is there anything you'd like to add?
Well, I just want to say thank you for listening, and as you can probably tell by the way I spoke about everything, I'm very passionate about what I do. I may have gotten into things that maybe, a lot of you didn't understand. I apologize for that. But what I can say is I truly enjoy being a nurse coder, and I hope some of you will actually consider becoming one and either expanding your career or getting into a new career as a nurse. Thanks for listening.
Thank you, Judy, and thank you everyone for attending. Have a good afternoon.